Just in time for the first bench of 2021. Welcome you all, and welcome to Dr. Lois Ombajo. She's the head of the Infectious Diseases Unit at the Kenyatta National Hospital, also a senior lecturer, University of Nairobi. Recently awarded MBS.
You've been out for too long.
I've been too long. And Dr. Githinji Gitahi, the group CEO, Amref Health Africa. You had an MBS a few years ago as well. Yep. So welcome MBSs.
Thank you.
Congratulations.
Thank you so much.
Well done.
Thank you.
How did that feel? Were you surprised?
Yes, I was.
Oh, well done. But she worked hard this last
She shouldn't have been surprised. I've been telling her she's doing a whole lot. So.
Oh, thank you.
Yeah.
Thank
keep
you
it
so
up,
much.
Keep it up. I know we always bother you guys, and we're going to keep bothering you until we get this thing right, because you guys are the experts. And the parents out there have a lot of questions for you. So please indulge us. And thank you for coming on as my first guest of 2021.
Thank you for having us.
All right, good. So you saw schools open this week, guys. My goodness, Dr. Lois. And yeah, I remember when I was interviewing you when I was home with COVID, remember that time? And your son was in the room, he was running in and out. So obviously you know what it's like.
Oh, yeah.
Tell us your experience.
So this week has been a little scary. I imagine every parent has been a little anxious with getting the children back to school. But the kids are really excited. They've been home for a long time. They're waiting to see their friends. They even missed their teachers and schoolwork. But the kids are excited about it. Of course, there's a bit of anxiety trying to figure out, have I taught my son enough that he'll keep his mask on? Chances are he'll keep it on when I'm looking at him, or when the teacher is looking at him. Most children will probably remove them along the way, but it's going to be a journey of learning for everybody. Yeah. And I think the main thing is, at some point we were all wondering, what are schools doing? What are schools doing? And it should be dawning on us, what are we doing to prepare our children for school?
You know, my son says the hardest thing for him is keeping his mask on for 70 minutes. That's the duration of a class. 70 minutes. It's hell for him. It's hell. Dr. G, your boys, how are they coping?
Well, it's the same. I think the experiences are the same. That it's going to be challenging. Yeah. It's going to be challenging, and we realize that. And I think we just need to kind of allay the fears of parents and say, it's okay. And we need to explain that. You know, at some point when you're ready, I'll explain, you know, what I think should kind of give people hope that even if the mask is not worn 100% of the time, the other measures that combine together to make sure that we keep the infection at bay. So we should not over-focus on one particular issue. We need to look at the holistic issue, because again, remember that we don't have community and schools. Schools are part of the community. They're part of us. We don't have children who go to school and parents. They are together. It's one family. And even when these children are at home, they are also exposed. They're also at risk from their parents who are going to work, from their brothers and sisters who are going to school, the university, they're going to school. They're also at risk. And also remember that schools don't exist in isolation. They're in a community. And the way that community controls the infection also is also a reflection of how the school will also respond to that. So it is one community. It's not schools versus us. And I think that's important for us to understand.
Sure, and I'd love it for you to go to the board. We'll go to your board, and I love props, which is great. Thank you for bringing the props. We'll go there in a moment. Doctor, let me ask you real quick. How do you tell a child to social distance from another child? Yes, they'll do it for 30 seconds, and then after that, boom, they're right there next to each other.
They're playing with each other.
Kids are kids.
I think one of the things that may probably make us feel a little better about children going to school is that we know that children don't transmit virus to one another as much. And we've learned this from countries that have already opened schools in the past. Children-to-children transmission tends to be minimal. So that should give us some courage, even as our children go to school. And some of these things, we just have to keep repeating them. You know, they'll forget it, and they have to keep being told, and they'll distance in class, and they'll go to the field and run and play and fall on top of each other. And I think it's just really encouraging children over and over. Keep your mask on as much as possible. You know, luckily they're out there playing in the sun, you know, when they're all on top of each other, it's not in a little room. So that helps as well, because in those circumstances, the transmission is also reduced.
And Dr. G, the teachers have to have the masks on.
Yes.
All the time.
Exactly. Because from what Lois is saying, from science and from the countries that have done studies, because they have had huge, numbers of students going to school, we know child-to-child transmission is very, very low. So what we actually have is adult-to-child transmission. And child-to-adult transmission is also very low. So it is really the teachers who should actually keep their masks on, number one. Number two is that the teachers should be the one moving class to class, not the students, because you reduce movement. So the advice is the teachers should be the ones that move from class to class. They're fewer and they keep their masks on. And maybe even allow for breaks between classes. So the teachers go out, there's a bit of open windows. So it's all these things that we have to do together. But it's important that the teachers wear their mask all the time. But you know, Jeff, even many of us, when you're told to travel on a flight for 9 hours, and they're supposed to put a mask on for 9 hours. It's, there are those challenges. Yes. So occasionally you'll need to take a breathing break, put it back on. It's not a death sentence, really. It's something that, as long as you're conscious while you're wearing it, then you know how to use it. You can even take a mask break, walk out of class, take a breather, take your mask off. As a teacher, take a 2-minute break, breathe, put it on back, go back to class. As long as you know why you're wearing it, then you know what to do with it.
That's very useful information.
Yeah.
Child to teacher, not so much. Teacher to child, much more.
Actually, in many of the countries where they've had schools open, the highest cases they've seen were amongst teachers. And teacher to teacher transmission is high. The one thing we learned early in this outbreak for us working in hospitals is that transmission happened where people sat in tea rooms to have tea, because these are people you're used to. You removed your mask, you were laughing, you were having your tea, and that's where a lot of transmissions happened. So even for the school environment, the adults in the school are at a little higher risk than the children in the school. So the adults in the school have to take a lot more precaution. The teachers have to think about which are the places where they meet together to have tea, to mark, to talk. Those are the places where the risk of transmitting to one another is higher. So they need to keep their masks on, they need to be in well-ventilated spaces, or to meet outdoors, for example. Those things that reduce transmission.
Yeah. Good points, good advice. Thank you for that. Dr. G, all right, let's go to the clipboard.
Okay.
What are you going to show? What are you going to tell us now?
Back to school.
Go. I love this. I love this.
Back to school.
Yeah.
So basically, what I wanted to explain here, Jeff, and I've talked about this. This is a child, okay? That's a child. And this is the virus. And where's the virus coming from? It's coming from people in the community. It's not coming from somewhere else. It's coming from us, from people. Now, when you have the people with the virus and the child is going to school, it's not one single thing that keeps the child safe. It's not saying that if your child doesn't wear a mask, therefore the child is going to get infected. Number one is that we must consider what is going on here. Are we allowing too many people with the virus to interact and therefore transmit it? And this is why even the public health measures have been extended, not only for schools, but for the community, because the school is part of the community. So we must think about our role on this side. The second thing is when the kids are going to school, we'll give them masks, but they'll not wear them all the time. I've even seen people saying they didn't come home with a mask, or they came home with someone else's mask, stuff like that. So that is one line of defense. But there's also another line of defense, which is hand washing, okay? So you have hand washing, another line of defense. If that doesn't work, then you also have social distancing. So these three, plus community behavior, all those working together, that's what we call the Swiss cheese strategy. If you look at Swiss cheese, it has holes. So you may have holes, so meaning that this virus may pass the first because the kid was not wearing a mask. So it may pass, and then you have the virus there. And this may pass, but then you have another layer. So maybe if you have, by the time it goes through all these layers, the child is safe. So it's not one single thing. So we must focus on the entirety of the school environment, the entirety of the community environment, and not overemphasize on one single thing. That is really what I want to demonstrate here.
Yes. By the way, I love Swiss cheese. I love Swiss cheese. I prefer camembert.
Next time you're eating it, you'll remember
exactly. That's very, and for those who don't know Swiss cheese, it's that's the cheese, and then it has holes. Okay, so we are saying if you layer many pieces of Swiss cheese together, if you pour water on it, some water will pass. But then over time, if you have too many layers, the water doesn't pass at the end, despite the fact that the one has holes. So we should not expect any of these to be 100% obeyed or complied with, as long as we have many, and maybe you have 50% here, 60% there, 90% there. At the end, you have a safe population.
Wow.
And Oh yeah, well done. You're a good teacher.
I'm telling you, I mean,
that's
it's as simple as that.
It's simple as that.
But Dr. Lewis, let me ask you this. Okay, fine. So your kid comes home with a different mask, someone else's mask. Yeah, we swapped masks, blah, blah, blah. That's one line of defense destroyed, right? In school, not all schools have those hand washing dispensers, whatever, right?
Yep.
That's another line of defense you've destroyed. And in the social, I mean, what do you do? Schools that are so far away, schools that are mashinani. Kids can't afford a 30-shilling mask. They don't have one.
Yeah.
What happens to those?
I think there's something Dr. Githinja said that's very important, that children come from a community. If we go back to, was it end of October, early November, when the phased reopening started, so when the grade 4 and class 8 and form 4s opened, we began to see a spike, I think within a day or two of the schools reopening. It wasn't as a result of school reopening, it was as a result of our behavior in the community. That's about the time when we had all these political gatherings, and there was a lot of gatherings. So the community spread increased. And these children come from a community. And when they come from a community, if we behave in such a way that we have so much virus in the community, then they will get infected. So the first line of defense is actually at home.
Exactly.
Let's not wait for the first line of defense to be in school. If you're sending your children to school and you're going out without your mask, you're the one who's coming to infect your child at home. If you're going into a gathering, you're the one who's going to infect your children at home. So our first line of defense has to be at home, has to be in the community. What are we doing in the community to keep the transmission low? Because as long as community transmission is low, there'll be fewer people getting into school with infection. So we have to think about community first. We have to create a safe environment for children to keep going to school.
All right, Dr. G, speaking of community, a lot of people have just come back from Mashinani, Christmas holidays, New Year's. You are out there, you were socializing, you were partying, whatever. You were on the beach with no mask. And now you're back in Nairobi.
Yes, and we are complaining about schools opening, okay? Let me add a point before I answer the question you're asking now, because there's something that Dr. Lois said about how much children get infected. In the total scheme of things, in this country, 50%, I don't know how many of our viewers know, 50% of our population is under 19 years, is 19 years and below. So we would expect that when we look at the 97,000 cases we have, that the people under 19 would contribute, proportionately to the number of cases out of the 97,000. Right. In actual sense, people under 19 only have 9% of the total 97,000. Okay? 50% of the population under 19 is contributing only 9% of our total infections. The bulk of infections are actually moving up to about 39, 40 years. It's that active gap. So you can tell actually, and these kids were in the community. They were not like, people have told me, they argued, oh, because they were not in school, therefore they didn't get, but they were in the community where the infections were. Why is it they only contribute 9% of the total infection? It's because of what Dr. Lois was saying, that child-to-child transmission, children have some form of innate immunity. There's science that shows that as well. So let's also put these things in perspective, that the risk is us, not the children, really. So now let me come back to the question that we have said this before, that of course we know the factors that drive the force of transmission. Crowding, people being in closed spaces, and contact, and especially when those 3 C's are together for a long time. And that, you can tell that those factors will definitely came together during December, because people are celebrating together, they were in closed spaces. I looked through the window into a few bars. They were quite full. I'm careful to say through the window. They were quite full.
We believe you.
There were people gathering for boozy and all this kind of thing. So people had close contact in crowded spaces, for a long time, in closed spaces. So we therefore expect that there will be some increased transmission and infectivity. So we expect maybe that should come up end of January, or maybe you might have a lag because of the way the virus travels from person to person. By the time you notice it statistically, maybe early Feb or so. But I think it's inevitable that we are going to have a small surge. Whether it's going to be big or small, we don't know. And we can't predict that. But there will definitely be some increase in infections because of those factors coming together during the festive season.
Dr. Lewis, should we be worried about that? I mean, like Dr. G says, it's obvious it's going to happen. It's obvious. Look what's happening in Europe. Half of Europe is locked down. Locked down. British Prime Minister Boris Johnson said kids will go back to school. A day later, boom, total lockdown. UK. Should we be worried?
We don't want to cause alarm. I think our populations, we've noted over time there's some population differences. If you look at how the virus has spread in different populations, we haven't seen as much infections and severe infections as they've seen in the West. I mean, there are various theories for that, maybe because we are young, maybe because we have a lot of sunshine. I mean, there are many theories that could explain that. But having said that, we also don't have too many resources, so we cannot afford a large outbreak. So for that reason, again, what we do over the next few weeks really determines what happens. This is a time when everybody should wear a mask. And I have to say, Jeff made us remove our mask. Everybody, everybody must wear a mask.
And look where you put your mask. I mean, you put it right there. Even you, doctor, it has to be on your person.
Next to me.
Next to you.
So everybody has to wear a mask because this is a time when everybody I meet out there could potentially be infected. So I have to protect myself and I have to protect those around me. And what we do over this next few weeks will really determine the size of any surge should we have one. So everybody has to be extra cautious. And remember, we're doing this not just for ourselves, but to also allow our children to go to school. So that's really, really important for us to remember.
Good point. Dr. G, you mentioned 97,000 Kenyans have tested positive, right?
Yes.
Well, close to 100,000. South Africa passed 1 million the other day, I noticed. What's going on?
You see, we have to distinguish between tested positive and positive. Those two are different things. Tested positive means you're positive, but you had a chance to be tested. So we know. Therefore, we announce those numbers. But being positive without being tested, you don't enter the 97,000, remember. So we know that there are people who are positive, but who are not tested, either because we had low testing capacity, or because they just stayed home, or because the virus came and they had no symptoms, it went away. We know that the number of people who've actually had contact with the virus and actually had an active infection without them having any symptoms is way more than 97,000. In recent studies, it may be estimated that maybe more than 10% have had contact with the virus. That means if you look at 10% of our population, they're looking 5 million people, maybe even up to 10 million people, we don't know, especially in Nairobi and Mombasa. So we know that the virus is more widespread than the numbers show. And the numbers are not meant to map the total infection. They're basically for showing you the direction of the infection of the virus so that you're able to put control measures. So always remember that 97,000 is only the laboratory tested positive cases, not the people who've been positive. So in Kenya we expect, because South Africa has much higher testing capacity than us, we've now tested about 2% of our population at about just 1 million tests or so. Remember, some of those are repeat tests, so maybe less than 2%. South Africa has tested a big percentage of its population. Huge. So you also expect that the cases they're reporting are also much higher than ours. So there are those things that we need to remember. But therefore, back to what Dr. Lois said, our biggest worry, and this is also really important for schools, is not about an infection. It's about what you do when you find out the infection so that you avoid other people getting it, so that you control the force of infection. And secondly, how many people who are higher risk or vulnerable does the infection go to, and then meaning they will require hospitalization, and then you have over-home system. So I must say that when the school started opening, we got 2 million kids in school, and there was big panic. And I saw the media. I must actually talk to you guys and say, I saw people saying, 68 girls test positive in this school. The question is, why were they tested? Were they tested because somebody felt it's good to do routine testing? Were they tested because they were sick? If you find 68 girls out of a school of 1,000 people, or 68 boys out of a school of 1,000 people who tested positive from routine testing, why is that an alarm? Because we know we already have infectivity in the community. If I was to come to Citizen and test everybody, I will expect to find positive cases. Should that be alarm? No, because that is routine testing. So the question the media always need to ask when you find, these schools have opened now, and you're going to see these stories coming up. Oh, this student now, 10 test positive. They should always ask, why were they tested? Is it routine because they said, oh, please come and test our students? Or was it because they were sick or because there was a contact? That's what is important, not the numbers of infected people. Those are irrelevant.
Dr. Lois, you're busy every day. You're overwhelmed and probably okay. How is it going, by the way, at Kenya National Hospital?
No, actually, over the last month or so, we've seen a decline in the number of severely ill patients, and that sort of mirrors the reduced number of infections that are reported, the reduced positivity rate, so to speak. It's real because in the hospitals we've seen a decline in the number of very sick patients. So hospitals haven't been overwhelmed. December has been a good month for us. We want to keep it that way, everybody. Please keep it that way.
Yes.
But at the moment we're seeing fewer cases. There's one other thing I wanted to say about children and going to school. We've given the responsibility to schools. All of us are looking at the schools. And as I said earlier, the responsibility starts at home.
Yeah.
And this is one of those areas where, for a parent, if your child is unwell, keep your child home. You know, don't have a child with fever and just send them off to school, because if they did have it, you're exposing other children. So you see, it's about caring for my child, but also caring for other children, that we really have to be conscious and say, my child has a cough, stay home a couple of days. Staying home a couple of days will not determine whether they become an engineer or not, you know. Keep them home a few days, then send them to school when the symptoms have resolved. So that's also part of taking care of one another at school.
Simple stuff.
Exactly.
Yeah.
Okay, doctor, you are head of infectious diseases. We all know that. There's a new virulent, or whatever you want to call it, or variant of the virus in the UK. 50,000 people a day were testing positive. You heard these stories, right? South Africa, the same thing. What is this new variant of virulence form?
Yeah. So the UK truly has seen probably the highest cases per day that they've reported since the beginning of the outbreak. And many viruses, not just coronavirus, many viruses, they multiply rapidly. They make mistakes in their genetic code as they multiply, and that results in some changes. Most of those changes, we never know about them. Occasionally, there are changes that may kill off the virus. Hopefully, they avoid changes that kill them off. And sometimes we have changes that may change either how well the virus multiplies or how well it binds to human cells. So for this particular variant that is causing more alarm, what has been noted is that the people who have this variant, so there's a change in the genetic code, which means the characteristics of the virus are a little different. It may bind a little better to human cells. And basically what they've noted is that there's a very large spike in a lot of people getting infected, even in areas where they had some control measures. So that's how they identify this new virus. And the main thing is that they seem to have a lot more virus around the nose and throat. And if you have a lot more virus there, it means you can transmit more, because with every droplet, there's a lot more virus coming out. And it's probably suggested that it increases the infectivity of the virus, probably somewhere between 40 to 70%. So that means that if one person was infecting only one, now we get to the point where one person could potentially infect 1.5, you know? Yeah. If it's more infectious, one person could potentially infect 2 people. So the rate of spread is a lot higher, and that really interferes with control measures, because it means if people don't wear masks, you know, that Swiss cheese, the holes are a little bigger, you know, and they can, more virus can get through. So that really is a concern. It's that it's being transmitted a little more than the original virus that was there. It hasn't been shown to cause more severe disease or more deaths. It's just that it's being transmitted faster, and because of that, control is a lot more difficult. Dr.
G, you seem to agree, but does that mean it's mutating? It's changing? Is that what it is?
It's a mutation, and viruses, mutate, as she says, all the time. Now, what happens is that if you have a mutation that is more severe, that kills the host, which is us, faster, the virus meets a death of its own. So it kind of disappears faster.
Because it's killed all the people it could infect.
Exactly. Because, and therefore mutations that are favorable for the viruses, not for the human beings, are the ones that keep the hosts healthy and alive longer, to multiply themselves and to transmit to the next person. Because the virus is not coming to kill you, it's coming to actually use you as a factory for itself to be able to transmit to other people, for it to propagate its own gene. That's the purpose of the virus. So the longer it keeps the hosts, the better for the virus. So the mutations that survive best are the ones that increase infectivity but reduce virulence. Okay? Ebola, the reason Ebola never really spreads is because it's a very virulent virus and therefore kills its host too quickly, so the host does not have time to produce multiple viruses and transmit them, because the host dies too quickly. So it is likely that this new variant will be highly infectious. Therefore, multiple people will get infected at a short time, and it's likely to come also here and everywhere else. But as Dr. says, it's not proven that it's more virulent. That's causing more severe disease. And it's in its benefit not to kill the hosts.
You know, I didn't even look at it that way.
Yeah.
If it kills a host, it dies.
It dies.
Yeah.
Wow.
Exactly.
You guys should come here every week, huh? You need to educate us more.
Yeah.
Okay, so while we're on that, Dr. Vaccine, that's the V word everybody's looking for now. In the States, about 4.8 million people, as of today, had been vaccinated. UK, Europe all over. We heard in the story earlier, we mentioned we're going to get it next month, Dr. I'm not putting any pressure.
So I think the Ministry of Health is best placed to answer the question of when it will get here. I know there was the news earlier that it may get here next month. Maybe that's probably the projection that they have, given the market forces that are there. Remember, there's a lot of competition for this vaccine. You can't just walk into a shop and buy the vaccine. There has to be a plan of who gets it, when do they get it, how is it funded. So there's a chain, and there are people also waiting along the road.
Yeah.
So the projection is probably what the Ministry of Health announced. We'll have to wait until we get it.
But it is coming.
It will come. It will eventually come.
And you guys will get them first, right? You healthcare workers, obviously.
We'll get them first.
Right.
I guess the good thing, people always ask this, should we get the vaccine? And you know, there's all these conspiracy theories about the vaccine. For the first time, we have, I don't know whether to call it an advantage or benefit, but there are other people who are getting it first, and we have the benefit of sitting back and observing, you know? So by the time it gets here, we probably have more confidence, because a lot of people around the world will have had it and will have had opportunity to see what are the side effects, what does it do to people. And I mean, so far there's no alarming news that should make us scared. So people should reduce on the conspiracy theories.
and those who are saying, I'm not going to take it, I'll never take it.
Believe me, Jeff, I've seen enough people die for me to say I will get it.
Yeah.
Dr. G, I want you to explain exactly what you explained to us earlier on, the process, but I want you to do it after the break.
Okay.
You know, how Kenya applies to so-and-so, and then so-and-so does so-and-so. I want you to explain that just so that our folks out there can see that, you know, we're not cheating them or whatever.
Exactly.
It is what it is, right?
It's what it is, yeah.
Are you going to take it?
I will do that.
And it's 2 doses, right?
It's 2 doses, within about 4 weeks or so.
weeks.
Yeah, I'll take it. And my family will take it. But of course, you know, Jeff, I'm 50 years, so I'm in the category of high risk. Therefore, I'm likely to get it soon after health workers.
You remember you're a health worker, right?
Okay, while you're still laughing, there are some people who will want to jump that queue. You know those people. You know who I'm talking about, right? They'll want to jump that queue.
That's the worry. Yeah.
There's a strategy that every country is adopting,
Yes.
and it's to start with healthcare workers. Yeah. And the reason it's starting with healthcare workers is because their exposure is more. They have to take care of people who are sick. So it's only important that you protect that workforce. Then it goes to the vulnerable people, the people who are at high risk for severe disease, which means children are not the ones who are going to be getting it, you know? Yeah. This will be adults first. So we hope that everybody will respect that hierarchy as we go on.
Dr. G, he's complaining he's 50. Look at this man. All right. Guys, this is such useful information. Let's take a quick break, come back, and let's talk about that vaccine and more. And I'm sure there's a lot of questions coming in thick and fast from you all. Keep sending them at Koinange Jeff at Citizen TV Kenya. Hashtag is JK Live. JK Live with the 2 doctors, the 2 MBSs. Look at this. Doesn't get any better than this. We'll be back in a moment.